So welcome everybody to the Alvimedica webinar titled Drug-Eluting Stent Role in Below-the-Knee Segment. Today, Dr. Marco Manzi from Italy and Dr. Marc Sirvent from Spain will drive us through a journey in which they will discuss when, where, and why drug-eluting stent in below-the-knee segment has a role, and which are today's latest clinical evidences. So without any further delay, I leave the stage to Dr. Marco Manzi. Thanks a lot and enjoy the webinar.
Thank you very much for your invitation and hello to everybody. Welcome to my lab. Sorry for the situation. I was working. Okay. My topic is BTK drug-eluting stents role today. This is my disclosure. We have to think that we started to speak about infrapopliteal stenting many years ago, exactly in 2006 with this paper by Thomas Rand about the possibility and the feasibility to perform a deployment of a stent in the below-the-knee arteries. But after this paper, a great time was spent in studying devices, in improve the size of devices in order to approach with stent this segment, very delicate stent, very delicate segment. So finally, in 2010 was published this paper about the effect, the efficacy of drug-eluting stents in the tibial vessel, and of course they concluded, and we are speaking about 11 years, almost 12 years ago, about the efficacy and the feasibility of the deployment of drug-eluting stents in this segment, because they concluded among which 240 patients, after 2 years, they had a quite impressive patency of 73%. And after 2 years in that segment was an impressive patency. Of course, the length of the lesion was short, of course, between 2.5 and 30 millimeters, so very short lesion according with the length of the stents. Then we proceed in the history of this topic in 2012 with the publication of the Achilles trial. The Achilles trial was is one of the most famous randomized study 1-to-1 performed by many famous and high volume center, performed with the Cypher stent from Cordis. The Cypher stent was a Limus stent, originally a coronary stent, and if we take into account the number of the patient, the number was very good, was a good amount of 200 patients divided 1-to-1, randomized 1-to-1 with the control arm where they perform the plain old balloon angioplasty. So after this trial, the clearest message was that for this kind of device, the ideal patient, the ideal lesion was and is the focal short lesion, even an occlusion, not necessarily only a stenotic lesion, but short and focal. You can see here these images are coming from that trial that they could identify the clear case for cipher stent, and you can see here the lesion in the tibioperoneal trunk in both cases was the ideal lesion. Of course, these patients, they have multi-level lesions, so we could not think that with the treatment of only a single focal lesion we can treat a CLI patient, but they have many lesions, but the lesion in the tibioperoneal trunk or in the proximal part of the tibial vessel as the ostium of the tibial vessel was the ideal area, the ideal site for the stent deployment. And this in this slide we can see the result of after 1 year with a very low what we call now is a TLR. So despite the large amount of restenotic and reocclusion in the arm of angioplasty, plain old balloon angioplasty, only 17% in the arm of drug-eluting stents had a restenotic lesion, and so a TLR. So after this paper, many other groups dedicated their attention to this topic. So, for example, this is a vascular surgery group, an Italian vascular surgery group. Roberto Silingardi is the first author and a good friend, with again a large number of patients, 155 patients with almost 170 limbs, and again a very low TLR of about 10% after 1 year of follow-up. So in this area, a very good result. We know exactly that in this area, the amount of restenotic recoil, reocclusion is very high, as we could see, I think more than 50% as we could see in the previous paper. So again, 2017, Marc Boisier demonstrated again on a group of 60 patients to have a similar TLR of 15% after 1 month, after 1 year, sorry. And in 2018, even in Texas, so in an American group, they started to check this possibility in, of course, a smaller group of patients, only 21. But again, you can see here 2 patients, they needed to be retreated. 2 patients died, and in the most of patients after 31 months of follow-up, the lesions are completely patent. So we arrive to 2019, where Ramon Varco and his group in Sydney performed this important meta-analysis, and they concluded that the drug-eluting stents applied in this area, they have a better patency compare bare metal stent, compare plain old balloon angioplasty, even compared with the drug-coated balloon. They have less hyperplasia and a better quality of life. And finally, but I don't want to speak about this paper. Marc is with us this afternoon, so will illustrate better than me his experience. I found it very interesting and very important for this this topic, and is the experience of this year. So from the theory to the practice, our indication, our everyday indication recently has shifted, because we started, because my opinion was always we have to be really prudent in the use of stent in general in the diabetic patient, because the natural history of the disease is very clear, is very renew. So in their life, diabetic patient, they usually have the need to be treated more than one time. So when we have a stent, if the stent has an occlusion or has a fracture, the revascularization, the further revascularization procedure could be much more difficult than the first one. So in the beginning, my indication for the stenting in this area was only when we have a bailout situation. So when we need to scaffold because we have an acute recoil because of the presence of calcified plaques or severe calcification, or when we try to dilate with the plain balloon and the result is very poor, or so for example in this case we have of course an acute recoil mechanism, or again when we try to perform an angioplasty, a plain old balloon angioplasty, and we wait some minutes, 10 minutes, and we realize that the recoiling mechanism can always occur. So we have to scaffold in this case. We wanted to scaffold in this case, and you can see here after 12 months, the vessel is very good patent, and the stent has no signs of a hyperplasia and no signs of fracture. Again, when we have to reconstruct this kind, this area, when we have to reconstruct a bifurcation, and we achieve very bad dissection like this, we thought that despite a prolonged inflation with the balloon, we thought that this scaffold was needed. So originally we started to deploy stent just for bailout situation, like all the situation I showed you till now. So dissection, recoiling. But when we think if we want to reconstruct completely a trifurcation like this, we know that probably the only way to achieve a nice acute result and a durable result in the time, probably the solution given from a drug-eluting stent. So in this case, the create deployment could be a very, very good option and a nice solution. So that's why in the last time, you can see here, again, another case of reconstruction of the trifurcation. In the last year, I think, maybe 1 year and a half, I decided to go straight for a direct stenting and a primary stenting using this this create stent. So for me, it was an important modification in my mind, an important change in my mind from my bailout to a direct treatment. It is not, at least for my character, for my experience, is not a poor difference. It was a big step in my mind, but I really believe that the choice could be the correct one. You can see here the nice acute flow. So I can show you, this is one of the last procedure we perform. You can see here there is there are some fellows, some attendees. It was a workshop, and of course is a diabetic patient with lesion in the foot. We are performing the CO2 angio, and of course the trifurcation area is involved in a lesion. We have only a good posterior tibial artery arriving into the foot with two plantar artery, and the outflow is limited. So you could see again a lesion in the tibioperoneal trunk. So we first started to try to recanalize the anterior tibial artery and the pedal artery. We arrived into the foot, we checked the outflow. It was possible to see the existence of an outflow, so the attempt of recanalization of the arch in order to give a good outflow to our recanalization. You can see the small balloon we use to predilate and to perform the angioplasty so distally. So again, another check of the outflow. The lesion was around the fifth. You can see the osteomyelitis and the previous remotion of the apex of the fifth. Again, the dilatation in the arch with the two. You can see here the circumvolution of the artery, so the very high tortuosity in that area, and the aspect of the CO2 angio after the recanalization. So it's important to give a good flow into the posterior. You can see here the very bad plaque against the ostium of the posterior just before the origin of the peroneal artery. And so that's the demonstration. We go straight to the create implantation with no DAPS, and we can achieve a super acute result with a very, very nice improvement. You can see the spasm in the forefoot, but the acute result was really, really good. So from bailout to direct and to a primary treatment in this year is my opinion that, of course, we need to collect more results, to collect more patients, to check out our follow-up, of course, in the largest number of patients we can. But it's my conviction that if we decide to treat directly this area with this kind of stent, could be the best option, could be the best solution for our patient. Thank you very much for your attention.
Now we can move directly to the second presentation dedicated specifically on Create BTK. When we speak about Create BTK, we are speaking about a completely different technology in relation of the drug-eluting stent. We speak about a completely different system, a completely different approach, because it's a polymer-free, but thanks to the Abluminal reservoir technology, the polymer-free could be controlled, the release of the drug, and perfectly directly to the vessel wall. The Create BTK is the first drug-eluting stent using not a pure drug, but a formulation made by sirolimus and fatty acid. And the combination of the two elements is extremely important because it's able to guarantee a very nice homogeneous distribution of the drug. The third pillar of this technology is the Bioinducer Surface, so a second generation carbon coating helping the bio and demo compatibility. And the last part is obviously dedicated to the stent, because the stent platform has been created in order to maximize the mechanical aspect. In the next minutes, we'll deep dive these 4 chapters in order to understand clearly the characteristic of the Create BTK and the approach of the Alvimedica drug-eluting stent. Starting with the Abluminal reservoir technology, as you can see from the pictures, this kind of technology is the capability to create some grooves on the abluminal surface of the stent where the drug is loaded, and is loaded without the use of any kind of polymer. Obviously, since we have a position of the drug from an abluminal point of view, the release of the drug is maximized to the arterial wall. And extremely important, this kind of solution helps to have a protection of the drug during the navigation, during the introduction of the catheter and the stent in the different devices, in order to deliver in the proper way and the 100% of the drug only on the target. Obviously, the reservoir are positioned in an homogeneous way on the stent surface in order to have an homogeneous distribution of the drug. But the main characteristic of the Abluminal reservoir technology is the capability to control the kinetic elution of the drug without the use of the polymer. Thanks to the Fick law, we are able to settle a design and specific kinetic release of the drug that basically is driven by the design and the shape of the reservoir itself. And the deliver on top obviously is on the target, on the artery, but is specifically designed in order to be sustained over the time. What it means that without the use of any kind of polymer, we have a high concentration during the first days, a release of the 50% approximately during the first 18 days, at 1 month, the release of the 65%, and the complete elution of the drug without within the 3 months. What it means? It means that without the use of any kind of polymer, we are able to have a sustained release of the drug over the time. And this is extremely important for a drug-eluting stent. But Create BTK is also the first drug-eluting stent using a formulation made by sirolimus and fatty acid. The role of the fatty acid is extremely important because it's able to sustain the release of the drug, modulate the drug bioavailability, and to have an homogeneous distribution of the drug itself. But it's fundamental to release the fatty acid at the same times of the sirolimus in order to have a combined effect and an emphasization of the role of the drug in the release coming from a drug stent. The role of the fatty acid is crucial because if we release a pure drug, we have a high concentration of the drug at the topic level, but inside the tissue, the drug concentration is decreasing. If we are using a fatty acid in combination with the sirolimus instead, we are able to sustain the release of the drug into the tissue in order to have an improvement in terms of drug distribution. And this is why, because the fatty acids are able to pass into the membrane in a very easy way. And in the meantime they are passing, they are bringing with them the sirolimus. So we are able to emphasize the role of the drug using fatty acid, but at the same time working in the same mode. Another important element is the Bioinducer Surface. The Bioinducer Surface is a second generation of ultra-film film, because we are speaking about 0.3 microns of pure carbon. And the role of the Bioinducer Surface is extremely important because it acts in interfering with the bloodstream and as an interface with the tissue. And the reason why we are using this technology is because we need to increase the bio and hemocompatibility, because we need to have immediately an antithrombogenic material in contact to avoid any kind of thrombus formation, but we need to have a very fast endothelialization of the stent. And the bio-inducer surface is able to guarantee these two important aspects. Moreover, the bio-inducer surface, it's able to block the release of all kinds of ions. What it means? It means that in contact with the artery, in contact with the bloodstream, we don't have the pure strength, but we have only the carbon surface, so something of extremely compatible. We are speaking about carbon, but we need to apply this kind of coating without modifying the mechanical aspect of the stent. And this kind of coatings is matching perfectly also this feature. Last but not least, the bio-inducer surface, it remains in contact with the stent and together with the stent for the entire life of the stent itself, because we have an adhesion force of 700 kilo per centimeter square. So very high adhesion strength. But these three important pillars have to be matched with a dedicated cobalt chromium platform, because we would like to maximize also the mechanical aspect of the platform in order to emphasize the single element and the single features. First of all, with the Abluminal reservoir technology, we are removing material from the stent. But from the mechanical point of view, have or not have the Abluminal reservoir technology and the reservoir, it doesn't create any kind of influence, because there are positioned in some strategic point in order to have an homogeneous distribution, but without having an impact on the mechanical aspect. So it's important that the mechanical aspect settled from our R&D team and reflecting on the stent, it remains also in the present with the Abluminal reservoir. Obviously, in order to maximize it, to have an homogeneous distribution of the performance, we need to have some small adjustment inside the family of our devices. And starting from the 2.25 up to 4.5, we have 4 different families in order to have an homogeneous performance in terms of radial force, vessel coverage, geometry during the expansion of the cell, and we have a differentiation in terms of thickness of the stent, 70 for the small one, 2.25, 80 for the others, but we have also a different number of the cells in order to guarantee this kind of performances. Dr. Manzi stressed the concept of the bifurcation. Well, thanks to the design of our Create BTK, we have a very easy access to the side branch, because also the circumferential cell expansion we can create on the side branch is almost a ratio of 1:1 with the diameter of the nominal reference. So it means that we have a very homogeneous performance, homogeneous scaffold during this aspect with a 1:1 ratio. Last but not least, the precision is important, because the treatment of this kind of lesion is an important requirement to be precise, to not have any kind of mismatch. The design of the device, thanks to the midpoint connectors, allow to have no shortening of the stent during the expansion. As you can see from this kind of sketch, from the deployment, from the crimping process to the deployment, the dimension of the longitudinal distance, it remains the same. So it means that there is no shortening during the expansion of the Create BTK. These important features, in combination with the presence of the platinum markers, provide a very nice, precise placements of the stent, because we are able to identify perfectly the dimension of the stent thanks to the platinum markers. And not only in bifurcation, but also in tandem standing or precise placement in the ostial lesion. This is an important element, because we can guarantee a very precise implant of the Create. Obviously, it's important as a last point to provide a very large portfolio in terms of codes, in terms of options. And the Create BTK is available between 2.25 up to 4.5 in terms of diameters, and length between 8 up to 46. So just to recap, Create BTK is a unique stent for the treatment of the below the knee segment because it's providing three important technology of our Alvimedica portfolio. So it means the Abluminal reservoir technology, so the capability to have a controlled dilution of the drug through a polymer-free platform, a completely different approach in terms of drug because we are using a formulation, because the Amphilimus formulation is made by sirolimus plus fatty acid, and the role of the fatty acid is crucial to maximize and emphasize the role of the drug. The stent is permanently coated with a bio-inducer surface, so a surface able to have a very high bio and hemocompatibility characteristics. And last but not least, the optimized platform is matching the requirement of the below the knee segment. So without any doubt and losing any time, I would like to give the stage to Dr. Marc Sirvent, because from the theory, we need to move to the practice.
Thank you for the presentation. Good afternoon to everybody. After these two great presentations, I'm going to share you our experience and long-term follow-up data with great below the knee stent in this area, describing our results and showing some clinical cases as examples. These are my disclosures. Well, we are conducting a prospective single-center study of drug-eluting stent in below the knee area. We started in the February 2016, and we continue including consecutive patients who have been treated by placing a disc at any below the knee vessel, regardless of any other additional therapy. Currently, we are analyzing the most recent follow-up. Unfortunately, I cannot release it yet, but I can anticipate you that the results are very similar to what I am going to share you in this presentation, but with more follow-up, which is great news. In the first part of this presentation, we are going to describe the initial follow-up, the first follow-up. It means until October 2020. And we included all the stents, not only Create, we use in this period. In this way, the aim of our study is to evaluate the efficacy and safety of the infrapopliteal drug-eluting stents in patients with critical limb ischemia. These are the primary and secondary endpoints analyzed by clinical and duplex examination, TLR, limb salvage, primary patency, secondary patency, lesion healing, and obviously overall survival. We included 36 CLI patients treated with 66 drug-eluting stents. As you can see on the slide, 90% of the patients were rated for class 5, and the majority of the stents we used were Create, as you can see on the right side of the slide. The baseline patient's characteristics, you can see there. Here, the median age was 75 years old, and around 80% were male. More than 70%, as you can see, of the patients had diabetes, hypertension, and dyslipidemia. The baseline lesion characteristics. The median total lesion length is 100 millimeters, and the median stented lesions length is 34. All the stents were placed, as you can see on the right side, in the proximal part of the below the knee vessels, following this distribution. At 24 months, the primary and TLR, the primary patency and the TLR was 78%, and the secondary patency was more than 90%, 97%. Limb salvage rate at 24 months was 92%. And regarding healing, around 74% of the patients had ulcer healed at 12 months and at 12 months after revascularization, and 80% at 24 months. So far, I have showed you the first follow-up of our study, which included all drug-eluting stents we placed in the below the knee vessels, because before we had the Create below the knee, the Create stent available, we use other drug-eluting stents in this area. However, we had the feeling when we started to use the Create, we had the feeling that we had better results using the Create, and we wanted to analyze it. In this way, we analyzed 42 celiac patients treated only with the 66 Create, the below the knee stent, until the follow-up was until the April 2021. We currently have seen more patients, but they are not yet analyzed. Here you can see the patient's characteristics, and the median, the main age was 76. The diabetics more than 70%. The 80% of the patients were class 5, even 6. We included some patients with Reservoir class 6. And according to the GLASS classification, the infrapopliteal class 4 was the 66%. And we had 54% of the inframalleolar glass P1. Here you can see the lesions characteristics, with the median lesion length was longer than before. The same happened with the median stentic length was the 35 millimeters. The stent location was again in the proximal part of the below the knee vessels, following this distribution. The majority of the patients receive only one drug-eluting stent, but in 31%, we place more than one drug-eluting stent in the below the knee vessels in the same vessel, even the 3 and 4 drug-eluting stents. And these are the results at 24 months that you can see are even better than those found in the first follow-up, where all drug-eluting stents that we use in below the knee vessels were included. So for that reason, when Create stent became available, it quickly replaced the other stents. And nowadays, when we consider to place some stent in the below the knee vessels, we only think about and use the Create. Here you can see summarize the results at 24th month and the Create experience in our center. So achieving a very good or fantastic limb salvage up to 95, more than 95%, with this primary patency the same from the telegraph, and the secondary patency is quite good. And almost in fact, 95% of the patients had their ulcers healed. So let me go move some examples to show this kind of the patients. So the first case is a total occlusions of both tibial arteries and the proximal part of the peroneal, with a severe disease in the tibio-peroneal trunk, with a good runoff through the peroneal artery. Here you can see enlarged the target vessel is in the proximal part of the peroneal and the tibio-peroneal trunk. We try to recanalize these lesions by an integrate approach, but we failed. We perforated the artery. So we try to recanalize the peroneal artery, the lesions of the anterior peroneal trunk, by using a transcollateral approach, because the patient, the leg of the patient, was very big. We use O45 or 14 guide wire using supported with a low profile balloon. You can see how the guide wire follow the vessel by the retrograde approach, and then we predilate from below to create in order to create a channel and advance a second guide wire from the above and continue the procedure from above. In this case, we place 3 create stents. At that time, we didn't have available the longer one, the 46 millimeter stent, and the longer was the 38. 30 months later, we had to perform a contralateral limb endovascular revascularization by a crossover approach. And at the end of the procedure, we checked the stents placed 13 months before, and we found no defects, as you can see on the slide. 13 months later, the vessel was perfectly patent. The second case, please notice the date. The second case is a total occlusion, a short occlusion of the beginning of the posterior tibial artery and severe disease in the tibial peroneal trunk with a good outflow through the posterior tibial artery. We place 2 creates. This creates. This is the final result. It's a very nice result, in my opinion. But difference 18 months, the date is wrong here. So it's 18 months later, in August to 2019, I think. We had to perform the revascularization of the proximal part of the FemPop segment and check the 19 months later and check how was the area treated using the create. So it's perfectly patent 18 months later. Finally, the third case I like to show. This is total occlusion, the anterior tibial artery, the posterior tibial artery, and severe disease in the proximal part of the peroneal artery. This is the result after dilatation, POVA, using POVA. You can see the flow limiting dissection in the proximal part and the anterior tibial artery. We place a create, this create 3.5 by 46. This is the final result. And so 9 months later, we had this occlusion, a symptomatic occlusion. So we had to perform a new reintervention of this patient, but I don't know if Marco has the same feeling or the same experience than me, but in most of the cases of the reintervention, we find distal proximal disease progression with stent patency. As you can see in on the slide, the patency, the completely patency of the stent. So we have proximal and distal progression of the disease, but the stent is patency, which make intervention easier. So in conclusion, Drug-eluting stent seems to be really good therapeutic option for a short medium lesions. It means less than 6 or 7 centimeters, and is also supported by evidence, as Marco showed us before. In our opinion, Create is the best stent for this type of infrapopliteal lesion because of its excellent results due to its distinctive design features, as Diego also showed us a few minutes ago. And after that, we consider Create a stent not only for the below situation as the beginning of our experience, but also as a first choice option in patients with proximal short medium lesions, especially occlusions, and especially if do not involve bifurcations. But this consideration is not an exclusion to place a stent for us. Finally, in most cases of intervention, as you can see in the last case, we find a distal or proximal disease progression with stent patency. Thank you very much for your attention. If I don't have, if some people has different questions.
Thanks a lot. Let me just first thank you for this presentation and for the important result with Create BTK. I would like to invite the audience, in case there are some questions, to take the opportunity to write on the chat. We have here two important experts, and they are available for to reply to the questions. And also, here is there is a question on the chat. What is the duration of the dual antiplatelet treatment?
Marco, you first.
Our protocol, we perform we suggest the dual antiplatelet for at least 6 months with aspirin and clopidogrel. And if during this period clinical symptomatic clinical reocclusion or restenotic occurs, of course we treat again the patient, and we recently try to suggest to change the antiplatelet, and we suggest to use the rivaroxaban. Of course, in our region is not still completely reimbursed by the public health system, but for particular situation could be administered. So 6 months with the common aspirin and clopidogrel, and then 1 year with the rivaroxaban.
Well, as you know, the evidence at that topic is very poor, especially in the peripheral field. So everybody does your opinion, their opinion. In our case, we are more aggressive. So the duration of the double antiplatelet therapy is at least 1 year. At least one year, not for due to I place a stent, because this kind of treatment, medical treatment, we do in any treatment, endovascular treatment. So in FEMPOP, in below the knee, it's the same, because we consider, so it's a chronic disease. The peripheral artery disease is a chronic disease. So in my opinion, we have to give the patient the most the best treatment. In my opinion, one key point is the medication after the revascularization. In our institution is at least 1 year double antiplatelet. Of course, if not, if there is not any contraindication, of course.
Marc. I have a comment. It's not a question. I have a comment, and first of all, congratulations for the fantastic presentation, fantastic cases you presented. And I agree completely with you about the possibility to, when we treat again the patient, whenever we had a progression of disease, I think, because curiously, the stent, it's in the most of cases still patent. So we have an occlusion or in the proximal part or in the distality, anyway, out of the stent. So it's possible to perform the recanalization in an easy way. My question is, I still do not have any fractures in the stent, especially I think that the most delicate artery for this problem could be the anterior artery in the proximal, from the ostium to the curve, to the first curve. We cross the membranes, the muscular membranes, so a stent there could be compressed, could be a subject, an object of many traumatic stress, but I didn't find any single fracture in the stent. Is it your experience too in this direction, or is
Yeah, it's the same. So it's this zone, this area is a problematic area because the membrane maybe is stress the stent. I didn't have any fracture, at least any symptomatic fracture. So it's maybe it's due to the design of this kind of stent. It's true that we had I think two patients, two fractures, but other drug-eluting stents, not the create. And yeah, for that reason, is one of the reasons I use the create. I changed when the create became available in our institution. It changed the stent. Another consideration, I think, is I don't know if it's your opinion, is I try to avoid the place the stent in the median or distal part of the below-the-knee vessels. I try to avoid it. I place the stent in the proximal part due to the muscles because the fractures maybe could be higher in this area. What do you think?
Yes, I completely agree with you. Probably in the proximal, medioproximal part is really the most correct site for this kind of stent deployment. Probably because in the distality, the artery is too superficial, so it's much more exposed, could be much more exposed to external trauma or compressions. Even a simple pair of shoes could be dangerous if you have a stent in the, for example, in the pedal artery. So I completely agree. I have never deployed a balloon expandable stent so far than the first third of the tibial vessel. There is another question from the audience. What type of balloon do you use for plain old balloon angioplasty, and for how long before stenting? So I think the question is, how do you prepare the vessel before deploy the stent?
Yeah, For two considerations that question. First, as you mentioned before, we changed the indications. We use this create and this stent, the create stent, not only for the bailout situations, but also the primary stenting in the situations that lesions less than 6 or 7 centimeters. So in this case, I use the create as a first option, so the primary stenting. So I prepare the vessel, or I treat the vessel using POVA, my first choice balloon, or my favorite balloon is the Tercuros from Terumo, because we can achieve high atmosphere pressure. So at least during 3 minutes, as a treatment. So it's the same for prepare before before placing the stent, or as a definitive treatment, at least 3 minutes. And then I check the result, and depend on the result, I use one tool or other tool, or more minutes dilatation or not.
So definitely you are going to deploy the stent when you achieved the best result. So that's the proof that we do not perform a bailout stenting, but we perform a treatment, a direct treatment with the stent. But the best angioplasty before the stent is a part of the treatment. Is not because we could achieve a bad result. So that's is a very good message, and I think it's probably one of the most important message we could give to the audience. So exactly the same, for example, when we decide to deploy a super stent, we have to prepare aggressively the vessel, and we have to achieve the best angioplasty result, and then we could be sure that our treatment with the stent will be the best treatment we could provide to the patient. So thank you, Marc.
Yeah, as the FEMPOP segment, the vessel preparation for me is mandatory. So to achieve is a part of the treatment. So the first step is vessel preparation, and then decide the best treatment, and the best definitive treatment. So I think it's a very good message. Yeah.
Are there any more questions?
I don't see anything on the chat. So I would like just to leave the stage to Enrico Roveda for the conclusion.
I would like to join the entire Alvimedica management to thank you, Dr. Marco Manzi and Dr. Marc Sirvent, for this very informative and interactive webinar. And for this reason, I just thank, of course, everybody also for joining and for allowing us to advance our knowledge in this specific field. Thanks a lot. Thanks a lot, everybody.
Thank you, Enrico.
Bye.
Thank you.
Thank you very much.
Thank you. Hack. Bye, Marco.
Bye, Marc. Hope to see you soon.
Me too. Bye.